appreciate the opportunity to talk a little bit about congenital scoliosis. I think we have a half an hour to talk about a topic that probably needs a lot longer, so we'll try to get through this. But, I think just basic understanding of what congenital scoliosis is. It's really a spinal deformity secondary to a vertebral anomaly that occurred during spinal development. And it's mistaken a lot, especially for scoliosis that's kind of early at birth or close to early in age, like infantile scoliosis. People kind of mess it up in assuming that any scoliosis that you are born with must be congenital, which is not always necessarily the case. And there's two types of scoliosis or congenital scoliosis in terms of its etiology, and that's the failure of segmentation and a failure of formation. And we'll kind of review both of these. In terms of, just thinking about the embryology of spine, every once in a while, I don't know currently, but it used to be on the OID is kind of understanding how embryology actually leads to pathologic processes, and for spine is probably the most kind of well-explained model, that at least I remember. And just the idea is that there are these somites that develop and split into basically sclerotomes and dermatomes, and then each of these sclerotomes then separates into two levels, which is basically the loosely packed cranial level and densely packed caudal level. It's actually the formation of the kind of the intervertebral disc spaces between these two. Why that's important is because the embryology of the spine is very segmental, and you can see that the kind of sclerotomes divide into the internal vertebral bodies, but then the dermatomes that actually follow the same segmental pattern, and that's why you get dermal distribution of sensory and so forth. The annulus fibrosis is from migrating cells from the densely packed layer, which then is responsible for kind of some of the disc material, and then the nucleus pulposus develops from the notochord and so forth. And you can kind of see just graphically how you get from the embryology or the sclerotomes into the development of the spine. Ultimately, these all then form into cartilage, which occurs about week 6 and 7. Ossification kind of develops at week 8 and beyond. And there's three primary ossification centers for anything subaxial down through the cervical, thoracic, and then lumbar spine. And then there's a centrum, and then 2 vertebral arches. For those that have operated under the age of 5, you know that there's what's called the neurocentral joints, which is basically the junction between the vertebral arches and the centrum. And it kind of is a pretty difficult part to get pedicle screws across. Basically, if you can see, the arrow kind of usually develops in this area right here. Initially, the entire spine, in a fetal position, if you think about it, is kyphotic. And then as the kids are learning to hold their heads up, that develops into cervical lordosis. And then really lumbar lordosis starts to develop once people and infants start sitting and then developing their standing posture. If we look at congenital scoliosis from an epidemiology standpoint, there's about an incidence of 1 in 1,000 girls, more commonly than boys for unknown reasons. Common causes that we know of are certain toxic exposure, carbon monoxide in a mouse model, maternal diabetes, epileptic drugs, and there is a familial genetic incidence among families. But majority of it actually is still unknown. We just know that there's some sort of fetal insult with exposure through the mom. As I mentioned before, there's kind of 2 ways of classifying it: the failure of formation and the failure of segmentation. Failure of formation comes in various different forms. And first one is it sounds exactly the way it is. So some part of the vertebral body hasn't formed. So wedge vertebra is essentially an asymmetric vertebra, with one side being relatively hypoplastic to the other side. It typically is, there still is 2 pedicles. A hemivertebra, on the other hand, is the absence of one pedicle, and is essentially kind of a wedged vertebra that fills, typically both in the coronal plane, but also in the sagittal plane, half the vertebral body. There are, different ways of in terms of how, for example, formation of failure formation can actually lend itself to, a progressive scoliosis. And so there's some terminologies that are important to know, and that is whether a hemivertebra is segmented or unsegmented. And there's two sides to a vertebra. There's the caudal and cranial side. If you For growth to happen, you need to have the essentially a disc space. So if you have no disc space, then essentially there's no growth potential from the growth plates just between the disc and the vertebral body. And so segmented means that there's a disc above and below, and so on, with unsegmented being fused to the vertebra above and below. And so a completely unsegmented hemivertebra really has very little growth potential. A couple other terms that are important with hemivertebra is one is incarcerated, which is basically the vertebra above or below accommodates the hemivertebra. So essentially, the hemivertebra is kind of within kind of the alignment of the spine, and essentially almost the pedicles themselves all line up. A hemimetameric shift is when you have two hemivertebrae that are contralateral to each other and almost in essence counterbalance each other. And this can happen in about 15% of the cases. So there's a failure of segmentation in two portions of the spine. The closer they are together, the more they balance each other out. The farther they are, the more they develop their own independent curves. The second one is a failure of segmentation, and the first kind of most benign is a block vertebra, where essentially there's a complete connection between the two vertebral bodies above and below, kind of you see depicted here. The other failure of segmentation is when you get a unilateral failure of segmentation, so that there is a bar between one or two vertebrae. And I would love to tell you it's that distinct like that's pictured here, but just kind of gives you the example of what it represents. But essentially, it's not an actual physical bar across the two vertebrae. The other important thing, and we've learned, especially through thoracic insufficiency syndrome and so forth, that the ribs themselves can be an extension of the vertebra when it comes to spinal deformity. And so a bar could occur across fused ribs as well. And then obviously there's the mixed deformity, which is just a combination of failure segmentation and failure of formation. Can typically result in a severe deformity and is most commonly associated with Bacterial or Vater syndrome, we'll talk a little bit about. If we look at the natural history of congenital scoliosis, it's really dependent on a couple things. The type of anomaly, so a block vertebra is going to be benign versus a bar, and so forth. Patient age, the younger the patient, the more growth potential, the greater the risk of deformity. And then the location of the anomaly actually plays a significant with lumbosacral junction or cervical thoracic junction and so forth being kind of the most clinically visible, but also the greatest risk of progression. In terms of curve progression as well, it also happens when the growth is fastest, and that's typically within the first 5 years of life, and then when patients have their adolescent growth spurt. McMaster is, an important work within our literature, not just for essentially congenital scoliosis, but really for spine in general. And he went through and looked at the progression and natural history of the different types of anomalies and try to categorize them based on their progression per year. You can see here, while I wish I could tell you that this is exactly how it follows suit, it really gives you kind of a threshold by which to follow these patients for a block vertebra, which may be relatively benign versus a unilateral bar with a contralateral hemivertebra. In terms of other risk factors for progression, for whatever reason, if there's in the thoracolumbar region, and then again, I mentioned before, don't forget about the ribs. Rib fusions are another form of a bar across the vertebral bodies. I mentioned before a little bit of Bacterial and Vater syndrome. approximately 60% of patients with congenital anomalies will have some sort of another anomaly in the organ system. And that's basically because the spine doesn't develop, on its own. It is developing at the same time other organs or other extremities, for example, are forming, and depending on how significant the insult is, and at the specific timing, can result in other anomalies. So Vater syndrome is a vertebral anomaly, anorectal atresia, tracheoesophageal fistula, and renal anomalies, while bacterial has cardiac conditions as well as limb defects also associated with it. If we look at them in isolation, renal anomalies have about a 20% risk of finding something. It does typically make a difference, though, in terms of how many anomalies you see. So an isolated block vertebra or wedge vertebra, a lot less risk of having another associated organ anomaly. But if you have a mix, then, it's up and down the spine, then a much greater risk. Cardiac, 25% of the patients. These are the two things that I will go ahead and make some recommendations for screening for patients if they have not already been screened when they come to you. So typically for renal, I'll get a renal ultrasound, or it can be evaluated on the MRI. Cardiac patients, I don't typically order echoes, but I usually will just make sure that the pediatrician will know that there's some concern about this, and we'll let them determine whether they need any further cardiac evaluation. In terms of neurologic, it's really about the spinal cord, right? So we went through the etiology a little bit pretty quickly, but essentially the spinal cord forms at the same time as the vertebral bodies. So if there's an anomaly that develops in the vertebral body, you have to be aware that there can be an anomaly in the spinal cord. And depending on the paper, this can be as high as 35-40%. The things that we worry about: diastatomyelia, tethered cord, Chiari malformation, and intradural lipomas. I think this is pretty old data now in terms of 9% neurologic injury in patients with posterior spinal instrumentation and fusion with spinal dysraphism. I think we do a pretty good job of screening for these patients now. And then just in terms of musculoskeletal, I think the other commentary about, we're orthopedic surgeons. We rely on, for heart and for renal and other things like that. We can say, well, it's not in our wheelhouse. We don't necessarily look for those things. And so while we don't want to miss it, but this we can't miss, right? So if a patient, comes to you and you're evaluating them for their spine and you miss another musculoskeletal anomaly, it's unlikely that there's going to be another physician that's seeing this patient who's going to pick this up better than you. So remember to examine the entire body, look at all four limbs. And, it's really on us to find these, maybe not necessarily to treat them, but to find them. So how do we do all of this? Obviously, a good history and physical. The medical history is important. Review the systems. In some cases, the spinal deformity may be the initial presentation for an underlying syndrome. And so you may be the first doctor that they see from the referral process from the pediatricians. In terms of imaging, remember to get the entire thoracic and lumbar spine. I know you're all deformity surgeons and should be common at this point in time, but just because you have a congenital anomaly in the thoracic region doesn't mean you can't have it somewhere else. And that includes C-spine. I think this is one that I still struggle with, and I still see patients who have been referred, especially because in pediatric centers, there are some locations where the neurosurgeons do the cervical spine and the orthopedic surgeons do the thoracic and lumbar spine. And so, just remember to get the full spine. CTs is not something that I get routinely right out of the bat. I know it's the best way to define the congenital anomaly, but if a 6-month-old is coming to see you and there's no intervention at this point being contemplated, you can probably hold off the CT. Definitely before preoperative surgical planning is it critical. And, there's the paper that came actually out of San Diego long before I was even there that demonstrated that 3D recons can define the congenital anomalies even better than just standard CT. I would even say at this point in time, we're moving ahead to printing these 3D models, especially for preoperative planning, to really truly get the best view and visual of what the spine actually looks like. MRIs, as I mentioned before, MRIs are probably a need in all patients. The timing is of the question, and I think there's probably, I won't say controversy, but it's not very clear as to when the best timing is. Um, and the main reason is because in the really young patients, there's a need for potential anesthetic in order to allow these patients to get the MRI. The benefit of an MRI is sometimes the earlier you diagnose a spinal dysraphism, you might actually prevent further progression, because the spinal dysraphism could also be a reason for progression. The other thing too is that I do find that the MRI, such as the picture down below, can better define the congenital anomaly. And when I look at for predicting, progression, families don't only just come for you for the treatment; they want to know what the future looks like for their child. And so, when you see a patient, you gain a lot by understanding how it progresses over time. But that's pretty delayed for families to understand. Is my child going to need operation? Is this going to be surgical? Is my kid going to be okay? And so an MRI does provide a little bit of additional information in terms of, are there discs? If there's discs, that means there's growth potential, and obviously if there's growth potential, so I think the MRI is also important just with informing families about the type of anomaly and the risk of progression. In terms of non-operative management, remember that bracing is, while it's important that not all congenital scoliosis it can progress, it is important to document growth of anomaly, and see what the risk of progression is just by observing it. Again, I mentioned you learn a lot, but I don't want to suggest that observation is benign in congenital scoliosis as well. So we won't have a ton of time to go into indications for surgery and the types of surgeries, but because of time constraints. But a hemivertebra that is progressing and is only 25 or 30 degrees, right? You can continue to observe that till it gets to a commonly surgical number of 50 degrees, or wait till the patient's older. But that's probably a curve that is, if you continue to observe, you're actually doing harm and probably should have a surgical intervention. So in congenital scoliosis, or really any scoliosis in pediatrics, observation isn't necessarily always the most benign approach. Bracing is typically not effective. It can control the compensatory curve. So if you have a congenital curve in the thoracic region, you might develop a lumbar curve in compensation for that. And so the bracing is most likely only going to be effective in that compensatory curve. Does that mean I don't brace congenital curves? No, because again, not all some congenital curves are flexible, and especially in mixed anomalies, you can sometimes get them a little bit straighter in a brace. And so while it's generally not effective, it doesn't necessarily mean it should never be done. Operative management, there's two categories: prevention of the deformity and then correction of the deformity. Sorry, I'm just looking at time, and we'll go through these. So in situ fusion, not commonly done as much. Interesting enough is the Fox study group is a study group that's been put together now that's looking at congenital anomalies. And in their conversations, we talk about whether we should be doing some in situ fusions. Potentially in situ fusions might actually avoid some 3-column resections that develop later on. Because we can do big operation doesn't necessarily mean we should avoid the small ones. Hemiepiphysiodesis, this on the other hand is something that's kind of lost in favor, has kind of been lost. There are probably still some curves that are good for it, but the idea is if you have the convex side and you do a hemiepiphysiodesis, you essentially create a bar on that side, and as long as the concavity still has some growth potential, then maybe the patient can actually grow straight. It's almost kind of like a tether, but instead of putting in, a flexible tether in, you actually just create a growth bar on that convex side. Fusion and instrumentation, you improve the deformity by using the disc spaces that are open, try to avoid any big column osteotomies. These are pretty good when you have compensatory curves as well. The only dilemma with it is you typically have longer fusions, which is again less than ideal for young patients. I will say this is the most fun operation that I typically will do, and this is a hemivertebra excision. It really is, I think, probably the best operation that a pediatric spine surgeon can do. And the reason for it is it's an acute correction, followed by instrumentation. So you pluck out a hemivertebra. Typically, the ages to do it are between the ages of 3 and 5. You can actually get to it before compensatory curves develop, and the acute correction can be lifelong. And so what you've essentially done is you've created a small little block vertebra across your fusion that may actually let that patient have a totally normal life that's relatively inconsequential to growth because of its limited fusion. And then finally, there's the big boy on the block, which is the osteotomy BCRs, severe rigid curves. They're typically associated with mixed anomalies. There's really no disc spaces to kind of manipulate across. And obviously, they're both acute coronal, sagittal, and sometimes axial correction. The advantage of osteotomy and BCRs is that it shortens the spinal column typically, which will have a theoretically decreased risk to spinal cords, especially if you have spinal dysraphisms. Um, it is, in all terms, technically demanding with high risk of bleeding and neurologic injury, and so should be the kind of the last resort. As for fusionless surgery, this is something that's obviously well known in San Diego with the development of the growing rods or ultimately vectors. The idea behind it is for continued growth of the spine and essentially is, used for patients, whether it's congenital, early onset scoliosis, that have multi-level anomalies, but are not necessarily completely rigid. You do have to have some flexibility in the spine. If it's completely rigid, I don't generally think that these are great options. The idea is distracting the spine and correcting it through distraction through the residual open disc space that might occur in the mixed. I think the struggle that a lot of people have with congenital scoliosis, though, in fusionless surgery is typically the apex is the problematic portion of the spine, which is what you're expanding across. But the foundation sites, proximally and distantly, are the normal parts of the spine. And so a lot of people struggle with the idea of fusing the normal portions of the spine to treat the congenital portions. And so there's still a little bit of controversy of that. So in summary, for congenital scoliosis, remember the embryology. The embryology lends itself to understanding the problems that we see develop later on. It's, in terms of failure of formation or segmentation, but it also lends itself to remembering that, we still have to be a good physician and we have to remember that there are other anomalies. And so as we think about the spine, think about the other anomalies, you might actually save a life. You might actually find a congenital heart problem by finding them having a congenital vertebral anomaly. The progression of deformity. So remember this block, is less than wedge hemivertebra unilateral bar versus a unilateral bar and hemivertebra, or ultimately a mixed deformity. And when balancing, the options for deformity correction versus, complications. So if you can perform something that's simpler before you get to the VCR, that might actually be ultimately in the patient's best interest. Great. I think we left enough time for some questions, hopefully. Sorry for going through so fast, but pretty broad sweep on congenital scoliosis.
Awesome, Burt. Thank you for doing that.
Compared to like
Thanks,
5 years
Burt.
ago.
Yeah, you're welcome.
You guys hear me okay?
Yeah, we can hear you. Sorry.
Okay. That's all right. Compared to like 5 years ago, what do you think are the main differences in management? You make it 10 years if you need to, but like, what have you seen?
Yeah, no, that's a great question.
Really
first of all, I think one thing that we are a lot more confident in as we continue to go, and that's the treatment of heavy vertebrae, and feeling like we can operate on them at 3 to 5 years of age, and we have the implants to do it and the technical abilities to do it. So I think that that confidence has been gained. I think we're still struggling with, again, what I mentioned before, the mixed, congenital early onset, what's the best option. Um, you know, putting foundation sites in the spine, it has lent itself a little bit with, using the ribs as an anchor and maybe staying away from the spine. I think, for those who've used growing rods traditionally, I think, there's now even a little bit of a tendency, while it's not necessarily using vectors, but using at least the proximal anchors to the ribs to kind of stay away from what may be otherwise normal spine. And again, I think, the other thing too is while we've become safer with VCRs, and have the technical abilities to do it, there's a lot more conversations, even in the Fox study group now, of not necessarily doing VCRs. And maybe that'll lend itself to, doing, smaller, more benign operations earlier in life. So, I think, we're moving in a direction where sometimes the past is catching up with us, and understanding that, we can't abandon everything from the past.
It all repeats itself, doesn't it?
It does, right? It's the circle, right? Like, you see it in adult spine too. That you learn technical abilities, the implants get safer, the procedures, and maybe the right word isn't safer, but the implants get better, our technical abilities get better, right? And then, but complications take, years to develop, right? And so we're reevaluating our newest and latest based on the complications that are 3 to 5 years later. So, I think we're going through that same process when we see it in peds as well.
Keep innovating. Any other questions from the group? So I totally blanked on
Great job.
on introducing you, Burt. I'm so used to you being just part of the fellowship, but
Yeah, fair enough.
Burt
No worries.
Yaszay is now the chief of pediatrics up at the University of Washington. Pediatric orthopedics at the University of Washington is a huge friend of our foundation. Is the site leader for the GSO trip to Monterey. He's a dear friend of many of us on the call, and a phenomenal surgeon. So thanks, Burt, for being here. And yeah, it's great having
Absolutely.
you.
Yeah, no, I really appreciate it. Obviously, you guys have a stellar group down there, so anything I can do to be part of it and maintain that connection is awesome.
We miss you.
Cool. Yes, amen.
All
Thank you very
right.
much, Barry.
Yeah,
Thanks.
you're welcome.
Guys, have a great day.
Good.
Thank
All
you.
right.
Enjoy your days.
Take
Have a
care.
good
All
week.
right, bye.
Bye.
Bye, Bert. Thank you.
Bye.
Thanks, everyone.